My name is Hannah Kinney. I'm a physician and I'm a neuropathologist at Boston Children's Hospital. A neuropathologist is a pathologist who concentrates and studies the brain and the nervous system. And I'm a pediatric neuropathologist with a specialty in the development, neuroanatomy, and diseases of the child's brain.
My name is Rick Goldstein. I'm the director of Robert's program on sudden unexpected death in pediatrics. I was a general pediatrician for most of my career, and for the last years I've been a pediatric palliative care physician. For the last 5 years, Dr. Hannah Kinney and I have been devoting ourselves to the care provided for families who lose a child under unexpected, unexplained circumstances.
We have things to say to families now. We have things that have been learned in SIDS and through our work here, through the work of people internationally, and that these can be crafted to messages that can help families on a biological basis and that they will understand. So that's a question that's asked to me all the time. And my response to that is a model that we worked in the lab called the triple risk model. And that is that 3 factors come together for an infant to die of SIDS. A critical developmental period. This is the first year of life as the infant comes from the womb and must adjust to living outside the womb, changes in heart rate, changes in breathing, own temperature control. And these functions are regulated by the brain. Then there is the vulnerable infant. To me, a SIDS infant is not normal. I do believe that there are accidents in the crib and that there is suffocation in the crib, but by and large, I believe the majority of SIDS infants have an underlying vulnerability or disease process, would mean an underlying undiscovered disease. And that makes the vulnerable infant passing through the critical period and the night of death meets a stressor in the environment that cause all of us during sleep have drops in blood pressure, drops in oxygen, elevations in carbon dioxide. And that baby can't adjust to the challenges during sleep because it has a problem, we would say, in the brain. I think it's important to know that there are 2 systems in the brain, one that regulates vital functions during waking and one that regulates it during sleep. The waking system is shut off during sleep and we're left to the brain sleep system that regulates vital functions. That's why the baby can look happy and normal and breathing and there are no signs of any problem because it's when it goes to sleep that the problem is unmasked.
The issue of, well, how did this happen under my watch? Is there anything I could have done to prevent this? Is also a critical part of this. And the answer to that is something that I think we all in this field struggle with and all parents struggle with. I think the question means different things to different people. So when a parent is asking about whether it's their fault and whether there are things that they could have done to have prevented this, an important part of that question has to do with this sacred obligation that a parent feels for their child. And there's no answer to that. Of course, there's no way that I can reassure them or that I can make the pain go away. We parents, good parents, just feel responsible for their children and for what happens to them and for what happens to them for as long as they're breathing. There are people that are in the SIDS world who pay a lot of attention to risk factors in the sleep environment. And they might look at this question in a different kind of a way. The important thing to keep in mind, and an aspect of this that we feel very strongly about, is that risk factors are not causes. And yes, it's important to understand what may have been in the immediate environment of the child that contributed on some speculative level, but that is not, that's not the same as saying that it was the cause. And then there's our answer, which is we see strong evidence, we see emerging evidence, we continue to see new possibilities in this world, in this aspect of understanding underlying causes that are relatively undiagnosed by the medical world and invisible. Most of these children are healthy children who are just put to sleep.
In our research, we believe that the underlying vulnerability in the SIDS infant that makes it abnormal, him or her abnormal, is a problem in the brainstem. We're looking at the bottom of the human brain, and we see that there is the brainstem here in pink. And it's in this region of the brainstem that we have found problems with the neurotransmitter called serotonin. And this is a neurotransmitter that's involved in heart rate, breathing control in the system that is operating during sleep and as sleep stages become deeper. This is also connected with a region called the hippocampus, which is along the middle surface of the brain, and their interconnections, the brainstem and the hippocampus, talk to each other. We believe that SIDS is a problem in these circuits of the brain, so that when the infant meets a stressor, like he is lying face down in a pillow, a normal infant would get out of that. He would turn his head, he would shake it, he would wake up because the oxygen had dropped or the carbon dioxide had risen. It's as if there's an alarm clock within the brainstem. It senses the low oxygen or the high carbon dioxide. The alarm clock rings and goes off. The infant is aroused and turns his head. But in the SIDS infant, it's not normal because it has a defect in serotonin in the brainstem. And when that alarm, the oxygen drops low in the face down position, that alarm does not go off, and the baby does not arouse, and the baby does not turn its head. And I think when parents are asking this question, they're thinking of a struggle and of a flailing movements of the infant as if the airway was closed and they were breathing against a closed airway. When I say suffocation and a suffocation alarm, I mean that the baby is face down, the oxygen drops, and that's the loss of air. And the baby becomes, remember, the baby is asleep, so this is a death we think that's occurring during sleep, so the baby is not conscious. And this signal drops down, the alarm clock does not go off, and the baby goes on to die. And there's no evidence at autopsy that babies have struggled. Was the baby in pain? Was she or he in pain? We have no indication that there was a struggle, which would have implied a conscious act of being impaired. Also, I believe that SIDS occurs during sleep and that it is a silent process without struggle. We have no indication from the way the babies are found that it's otherwise. And I believe that the babies are not in pain, that they are already unconscious and in the process of having low oxygen and do not feel this process. Having spoken with really hundreds of
parents who've been through this, I know that question. They all ask that question. Was there anything that I should have known? Sometimes they observe things and they wondered, should I have sent my child to daycare this day? Should I have mentioned it to the pediatrician? 2 weeks ago, when I went to the pediatrician with a minor illness, I had this question and I never asked it. And it looms and it haunts people. That is a constant in this set of circumstances. But also constant in this set of circumstances is that after we do a careful, exhaustive evaluation of these children, the answer is no. We never find anything, or we rarely find things. Most of the time, good parents act in good ways. They're more attentive than doctors, that's for sure, and they care more than anyone else that everything will be okay for their child. So the straightforward answer is no. There's not something that could have been seen or could have been known.
I think that with the Back to Sleep campaign, there's been the recognition that having the baby sleep on its back at night decreases the risk of SIDS. Now that is a risk factor that increases the risk, but that's not a cause. It's not the cause. The cause may be a failure in the suffocation alarm. And the risk is increased because sleeping face down, you can get a buildup of carbon dioxide and low oxygen around the face. And if you turn the baby over, the baby's not in that risky position. But the baby still dies supine, and they still have a serotonin defect. And we found that babies who die supine and babies who die prone both have the serotonin defect in the brainstem. So we're not exactly sure of all the other risks that are internally happening in the body that causes the defect in a baby who's found supine. So as a result, the thinking is that if you could just make the baby sleep supine, you would eliminate the risk. You would eliminate the risk, but you wouldn't eliminate the underlying cause. And the underlying cause is still there, and I believe that that cause can be progressive or can express itself differently as the baby gets older and cause the death irrespective of the risk factors.
For instance, a child is found in the prone position, and we know that the recommendation is for the child to be placed supine. They may have been placed supine and found in the prone position, raising all sorts of questions. They may have been placed in the prone position for any number of reasons that seemed perfectly legitimate and caring in the moment. I think one of the differences in our focus on the science is that we also know that children who die from SIDS have abnormalities in their brainstem, abnormalities that have been shown in research models to lead to a failure to respond to otherwise modest threats. And those abnormalities are found in children who die in the prone position, and they're also found in just as high of a percentage of children who do not.
We actually looked at that question, is the baby who's found on its back, does that baby not have a serotonin defect? And that's why being on the back is safe. But we found in our autopsy studies that babies who die face down and babies who die on their back have the serotonin defect in their brainstem. Before I became a pathologist, I was a pediatrician. and I had a residency in pediatrics. And one night, I was alone in the emergency room, and at 4 a.m., the Philadelphia cops brought in a baby who discovered suddenly and unexpectedly dead. And the parents, it was a teenage mother and her grandmother who came in. And for some reason that I don't understand, they were not put in the waiting room, but they were put in the room while we were doing the resuscitation of the infant. And they were screaming and wailing. It was piercing through this 4 a.m. at night through the hospital. And the policeman next to me turned to me and said, "They did it, Doc." And the parents were in the room. And so there was the accusation to the parents in the midst of this unbelievably perfectly looking baby. And it was something that just connected in me that if I ever do research, I'm going to find out why this baby died. And it really brought to me the things that I treasure the most in my life, which is the need and the desire to alleviate suffering. That's why I went to medical school, to be a physician. So part of SIDS that was so compelling to me was the possibility to be able to help relieve suffering. The other was that it was a problem of injustice, that because there was no obvious sign of physical and the cop didn't understand, he assumed that the parents had in somehow foul play had been involved. And that spoke to my sense of social injustice. And I said, that is something I want to work on. And then even then, as I was trying to resuscitate the baby and couldn't get the heart rate started and the respiratory rate started, I thought, this is a problem with the brain. And I'm going to study the brain. And so it brought together my love of the study of the brain, my sense to end social injustice, and my desire to alleviate suffering. And that's what SIDS represents to me.
I think the passion for me comes from the families, from young families who are so wounded and so motivation doesn't capture it, but they need to deliberately live their way out of this, and the stakes are great. And being there and responding to a need that is met with isolation, met with all sorts of awkwardness among people that otherwise love the parents, love the siblings, but are just ill-equipped to deal with it. All these aspects of self-blame, all the veiled comments that get made at every step of the way. I think it feels very gratifying for me when I stand with those people, those families. And so that means a lot to me.
I have met such amazing people in the last 30 years of my life. None of them compare to the parents. And the parents are always an inspiration to me. I don't understand how they do it, and I look to them to help them, but sometimes I feel like they're helping me. And then I look to the incredible scientists. There has not been a person at Children's Hospital that I have gone to them that have a particular technique in molecular biology or proteomics or metabolomics, and I say, could you work on this problem in SIDS with me and bring this technology into the human autopsy? And the incredible people of this hospital and my colleagues outside this hospital has been an incredible experience.
the idea of discovery in what I believe is a very neglected area of major mortality in children that has been really approached for the last over 2 decades as just an environmental risk for suffocation, and has not really been approached from a scientific, medical perspective. I think that that's invigorating for me.
If you asked me, what, Hannah, would you like your greatest scientific contribution to SIDS be? Of course, it would be to find a cause and a treatment and a way of identifying the living infant at risk. But one of the things that I feel very passionately about is that I would be remembered for introducing the scientific method to the study of SIDS. There were many scientists who thought about SIDS way before me, but I feel that there was a sense that this was an accident, a mishap, an act of God, if you will, a bolt out of the blue. And what I have always said to the students and to my colleagues is that this is a scientific problem. This is an undiscovered disease or set of diseases. And if we apply scientific principles that are hypothesis-driven, we will come to an answer.
There is a message of hope. I can't make the pain ever go away. I can't even really fully understand the pain. That's a private aspect of this that people will carry with them. I can't make that go away. And at this point, I can't completely answer their questions. What I can say is that we discover new things every day, and that's a reason for hope. What I can say is that we have important things to say to families so that in the world of all possible things that might have happened or that could happen to their other children, I think that that enormous, scary world, we can scale it down and understand, because we understand certain contributing factors, we can understand risk in a different way, and that's a reason for hope, and that allows people to live differently. And I would say also that it's kind of the right place and the right time for something important to happen here. And that's why we're here, that's what motivates us.